morning everyone. Today's topic for continuous cardiac education is aortic regurgitation. Aortic regurgitation can be due to acute condition or a chronic condition. Acute condition, the causes will be infective endocarditis, aortic dissection or trauma. While in chronic aortic regurgitation, it can be due to bicuspid aortic valve, it can be due to rheumatic degeneration, a degenerative condition, hypertension, due to syphilitic aortitis, Takayasu aortitis, giant cell aortitis, rheumatoid arthritis, People's disease, and ankylosing spondylitis, as well as in patients with connective tissue disorders. Now, aortic regurgitation can be due to primary valve disease. The causes include congenital condition like bicuspid aortic valve, rheumatic fever, infective endocarditis, collagen vascular disease, degenerative aortic valve disease, or myxomatous conditions, traumatic conditions, or certain weight loss medications such as fenfluramide or dexfenfluramine. While it can also be due to primary disease of aortic root. It can be due to long-standing or uncontrolled hypertension in patients with Marfan syndrome, in patients with idiopathic aortic dilatation, in patients with cystic medial necrosis or senile aortic ectasia or dilatation, in case of syphilitic aortitis, giant cell arteritis, Takayasu arteritis, People's disease, and ankylosing spondylitis. Now, first we'll see about the chronic aortic regurgitation. So, in pathophysiology for chronic aortic regurgitation, severe aortic regurgitation may occur with normal effective forward volume and a normal LVEF together with an elevated LV and diastolic volume, pressure and stress. So, in accordance with Laplace law, wall tension is related to the product of intraventricular pressure and radius divided by wall thickness. So, LV dilatation also increases the LV systolic tension required to develop any level of systolic pressure. So, in AR, there is increase in both preload as well as in afterload. So, LV systolic function initially is maintained through combination of chamber dilatation and hypertrophy, which leads to eccentric hypertrophy with replication of sarcomeres in series and elongation of myocyte and myocardial fibers. So, in compensated aortic regurgitation, sufficient wall thickening results in normal ratio of LV wall thickness to cavity radius. So, under this condition, and diastolic wall stress is maintained at or returns to normal levels. In aortic regurgitation, LV mass is increased. As aortic regurgitation persists and increase in severity over time, the wall thickening fails to keep pace with the hemodynamic load and systolic wall stress rises. So, this results in decline in systolic function and LV function falls. Patients with severe chronic aortic regurgitation have the largest LV and diastolic volumes of any form of heart disease, resulting in so-called cor bovinum or bovine heart. As the left ventricle decompensates, interstitial fibrosis increases, compliance declines, and LV and diastolic pressure and volume rise. In advanced stages of decompensation, LA, pulmonary arterial wedge pressure, pulmonary arterial, RV, and RA pressure rises, and the effective cardiac output falls at first during exercise and then at rest as well. So, the normal decline in LV and systolic volume or the rise in EF fails to occur during exercise, and symptoms of heart failure develop, particularly those secondary to pulmonary congestion. So, in patients of aortic regurgitation, myocardial ischemia occurs, which can be due to diastolic regurgitation, which leads to increased LV volume and increase in LV stroke volume, which leads to increase in myocardial oxygen consumption, and it also related to decrease in aortic diastolic pressure and decrease in effective stroke volume, which leads to decreased myocardial oxygen supply. So, in AR, there is increase in myocardial oxygen consumption as well as myocardial oxygen demand, which leads to myocardial ischemia and which leads to LV failure. In clinical history, symptoms of reduced cardiac reserve and myocardial ischemia, most often they are present in 4th or 5th decade of life. The symptoms will be exertional dyspnea, orthopnea, PND, angina pectoris, and tachycardia. Tachycardia is present with emotional stress or exertion, which may cause palpitation and head pounding. In physical examination, signs of early stages of severe chronic AR are the result of widened pulse pressure. On palpation, apical impulse is diffuse or hyperdynamic and is displaced inferiorly and laterally. The augmented stroke volume leads to systolic thrill at the base of heart or suprasternal notch and over the carotid arteries. On auscultation, there is early hollow diastolic murmur immediately after A2, which is usually high-pitched bowing sound that is heard loudest at the left sternal border, which is decrescendo in nature, best heard in end expiration and in sitting and leaning forward position. The duration of murmur correlates well with the severity of AR rather than the loudness of murmur. When the murmur is musical, which is called as cooing down murmur, it usually signifies eversion or perforation of aortic cusp. Harvey's sign. When regurgitation is caused primarily by the valvular disease, the diastolic murmur is best heard along the left sternal border in third and fourth intercostal space. While it is caused by dilatation of ascending aorta, the murmur is audible along the right sternal border. Many patients have harsh, high-pitched hollow systolic murmur due to increased LV stroke volume and ejection rate, which radiates to coronary vessels as well. Austin Flint murmur may be heard at apex in severe AR. It is a low-pitched mid-diastolic rumbling due to jets from AR striking the anterior mitral valve leaflet, which leads to premature closure of mitral valve. A2 may be normal or accentuated when AR is caused by the disease of aortic root, but it is soft or absent when the valve is causing the AR. P2 may be obscured by the early diastolic murmur, thus S2 may be absent or single or exhibit narrow splitting. S3 correlates with increase in diastolic volume and is a sign of impending left ventricular failure. So these are the peripheral signs of chronic aortic regurgitation. Corrigan sign is prominent carotid and supraclavicular pulsations. De Muset sign is head nodding with heartbeat. Landolfi's sign is change in pupil size with every heartbeat. Muller sign is uvular pulsations along with heartbeats. Becker sign is presence of retinal artery pulsations. Rosenbach sign is liver pulsation and Gerhard sign is splenic pulsations. The lighthouse sign is due to blanching and flushing of the forehead. Traube's sign is pistol shot sound over femoral arteries. Hill sign, which is seen as lower limb systolic BP exceeding upper limb systolic BP by more than 20 mmHg. Waterhammer sign is high volume abruptly collapsing pulse, and Moynes sign is diastolic BP drop of more than 15 mmHg with arm raised. Here is the video showing presence of dancing carotid arteries, which is known as Corrigan sign. This is the video showing presence of De Muset sign, which is rhythmic nodding or bobbing of head in synchrony with the beating of heart. Sign. Now this is the schematic presentation for signs of chronic aortic regurgitation. In ECG, in patients with chronic aortic regurgitation, there will be presence of left axis deviation and left ventricular hypertrophy. LV diastolic overload pattern will be seen in moderate AR, which is seen as small Q waves, tall R waves, isoelectric ST segment and upright T wave in lateral chest bleeds. LV systolic overload pattern is seen in patients with severe AR, which is seen as T wave inversion, downward ST segment in lateral chest leads, and conduction defects in severe calcific AR and inflammatory causes of AR will be seen on ECG. On chest X-ray, apex is displaced downwards and outwards. On lateral view, LV is displaced posteriorly and encroaches on spine. Prominence of aortic knob and ascending aorta can be seen. Egg-shell calcification of aorta can be seen on X-ray. There will be pulmonary vascular redistribution and interstitial or alveolar pulmonary edema. On echocardiography, aortic valve structure and morphology and variations can be seen, or we can see the aortic root pathologies. We can quantify regurgitant volume, fraction, orifice area, central jet width and vena contracta width. Based on, we can quantify the severity of aortic regurgitation. We can also see LV function and its parameters like ejection fraction, LV and systolic volume and diastolic volume, posterior LV wall thickness during diastole. There will be presence of hollow diastolic flow reversal in DTA and ascending aorta, which is seen in patients with chronic severe aortic regurgitation, and diastolic fluttering of anterior mitral valve leaflet. So this is the severity, grading of aortic regurgitation. In patients with severe aortic regurgitation, the central jet width will be more than 65% of LVOT. Vena constricta width will be more than 0.6. Regurgitant volume will be more than 60 ml per beat. Regurgitant fraction will be more than 50%, and regurgitant orifice area will be more than 0.3 centimeter square. On angiography, contrast material is injected rapidly into the aortic root, and filming is carried out in right and left anterior oblique projections. So, in patients with severe grade 4 aortic regurgitation, the LV opacity will be greater than aortic opacification, and rate of clearing of the dye will be slower. In patients of aortic regurgitation, cardiac MRI can be useful for accurate measurement of regurgitant volume or orifice area. It also provides the most accurate non-invasive technique for assessing LV and diastolic volume, LV and systolic volume, and LV mass. It accurately quantifies the severity of AR on basis of antegrade and retrograde flow volumes in ascending aorta, and it is recommended when echo findings are suboptimal. In patient, now we'll see about the acute aortic regurgitation. In patients with severe acute AR, the regurgitant volume fills a ventricle of normal size that cannot accommodate the combined large regurgitant volume and inflow from the left atrium. Because the ability of total stroke volume to rise acutely is limited, forward stroke volume gradually declines. In light of limited ability of left ventricle to tolerate acute severe AR, patients with this lesion often develop clinical manifestation of sudden cardiovascular collapse secondary to reduced stroke volume and elevated left atrial pressure. In patients with acutely severe AR, they appear gravely ill with tachycardia, severe peripheral vasoconstriction, cyanosis, and pulmonary congestion. Peripheral signs of AR, as described earlier, are not evident as in patients with chronic AR. The early diastolic murmur of acute AR is low pitched and is of shorter duration as compared to chronic AR. On ECG, there will be presence of sinus tachycardia. Left ventricular hypertrophy can be detected as early as 2 weeks after the onset of acute AR. Non-specific ST segment and T-wave abnormalities due to subendocardial ischemia, hypoxia, acidosis, metabolic or electrolyte abnormalities can be seen on ECG. On chest X-ray, there will be pulmonary congestion, apical redistribution of flow in pulmonary veins, and widened transverse mediastinum in case of aortic dissection. On echocardiography, there will be increase or normal end diastolic or end systolic dimensions. There will be systolic wall motion will be normal. Premature closure of mitral valve and shortening of interval of diastolic flow across mitral valve can be seen. There can be presence of aortic vegetations, and we can also evaluate aortic root and ascending aorta for its dilatation. In patients of acute or and chronic aortic regurgitation, the natural history will be slightly different. In patients with moderately severe chronic aortic regurgitation and severe chronic aortic regurgitation, if the LVEF is normal, it is associated with favorable prognosis. However, once the patient becomes symptomatic, the downhill course becomes really progressive. Data has shown that without surgical treatment, death usually occurs within 4 years after the development of angina pectoris and within 2 years after the development of heart failure. 4-year survival without surgery in patients with NYHA class 3 or 4 symptoms is only approximately 30%. While in patients with severe acute AR, the prognosis is less favorable with only 10 to 30% survival at 1 year after the onset of symptoms. Now, on the management part of aortic regurgitation, aortic regurgitation can be staged as stage A, which is patient with at risk of AR, and stage B will be progressive AR, where AR is mild to moderate in severity and there are no symptoms. In stage C, there will be asymptomatic severe AR, where severe C1 is severe AR along with normal LV function and mild to moderate LV dilatation, while C2, stage C2 will be a patient with severe AR without any symptoms but having abnormal LV systolic function with depressed LV ejection fraction and severe LV dilatation, while stage D is patients with symptoms and severe AR. This is the flow chart for the management of aortic regurgitation. In patients with severe AR, which is stage C and D, if the patient is symptomatic, aortic valve replacement is class 1 indication. In patients where symptoms are not there, if ejection fraction is less than 50%, that is patient of stage C2, and if patients are undergoing under cardiac surgery, so aortic valve replacement is recommended as class 1 indication. In patient with asymptomatic severe AR, if EF is more than 50% and end systolic dimensions are more than 50 mm, aortic valve replacement can be beneficial. While in patients where EF is more than 50% and end diastolic diameter is more than 65 mm with low surgical risk, aortic valve replacement can be given as an option. While in patients with EF of more than 50% and normal LV dimensions, periodic monitoring is recommended. In patient with progressive AR, that is stage B, if patient is undergoing any other cardiac surgery, aortic valve replacement can be beneficial, and if patient is not undergoing any other cardiac surgery, periodic monitoring is recommended. Now the surgical options for AR will be one is valve replacement and other is valve repair. So for valve replacement, the valve substitute can be mechanical valve, bioprosthetic valve, homograft valve, autologous tissue procedures like Ross procedure and Ozaki procedures. So in patients with aortic annulus of more than 30 mm, if patient is young, mechanical valve placement is recommended, and if patient is old, tissue valve placement is recommended. And if aortic annulus is less than 30 mm, in patients who are of elder age, tissue valve or homograft or Ozaki procedure is recommended. While in young patients, if the etiology is non-rheumatic, Ross procedure or homograft or mechanical valve are recommended. While in patients of rheumatic etiology, homograft valve or mechanical valve placement is recommended. In patients where valve repair is possible, there are two techniques. There are cusp repair techniques, which includes the central plication, Trussler paracommissural plication, perforation patching, triangular resection, free margin plication, modified commissural plication, and leaflet edge reinforcement. While in patients with aortic root and annular techniques, the annular valve repair techniques include external annuloplasty and internal annuloplasty ring, while root techniques include David procedure and Yakub procedure. We'll see in detail about all these procedures. So this is the diagram showing aortic valve replacement, where we, after going on cardiopulmonary bypass, aortotomy is done approximately 1.5 to 2 centimeter above the aortic root. The leaflets are excised, and based on the sizing of aortic annulus, we can place the aortic valve either in intraannular position or supraannular position. Now the type of prosthesis can be mechanical aortic valve, bicuspid, bioprosthetic aortic valve, homograft valve, or autologous tissue valves. So mechanical valve, the advantage is its durability and good performance even in small aortic root patients, while the disadvantage include lifelong anticoagulation and associated risk. Bioprosthetic valve is beneficial in patients who are elderly and patients who have contraindication to anticoagulation, like young females who have not completed the family, severe peptic ulcer disease, and patients with ulcerative colitis. Homograft valve, the indications will be infective endocarditis, aortic valve plus root disease, small aortic annulus, and patients who have contraindications for anticoagulation. The advantages will be it facilitates reconstruction of complex endocarditis, low incidence of recurrent endocarditis, and low early pre-operation rate. This is a diagram showing which is showing Ross procedure. which is autotransplantation of pulmonary valve to aortic position, reimplantation of coronary arteries, and homograft valve in pulmonary position. So the advantages will be it provides superior hemodynamics. It is beneficial in patients younger than 50 years with active lifestyle and in patients with infective endocarditis. In Ozaki procedure, the procedure is described by Shigeyuki Ozaki in 2011, which involves removing the diseased cusp of native aortic valve, measuring the intercommissural distance, and shaping new aortic valve cusp from the patient's autologous pericardium that has first been fixated with glutaraldehyde. New aortic valve is recreated by sewing the leaflets into native aortic valve annulus and aortic root, providing a new functioning valve. So this is the diagram where the first figure shows excision of leaflets, the second figure shows commissure demarcation using the sizers, the C figure shows the leaflet reconstructions using the patient's own pericardium and the sizers, and D shows the leaflets in the new aortic valve leaflets sutured to create new aortic valve. The advantages will be natural movement of aortic annulus is preserved and the reconstructed aortic valve has significantly less pressure gradient and can be applied to almost all aortic valve pathologies, and there is no need for warfarin postoperatively, and low dose aspirin is used for 3 to 6 months. Now we will see about the aortic valve repair. So based on the pathology, we can divide it into 3 types, where type 1 is cusp motion is normal with dilatation of ascending aorta or cusp perforation, while cusp 2 is due to cusp prolapse and cusp 3 is due to restricted movement of aortic leaflets. Now in 1A there is dilatation of STJ and ascending aorta, so which can be repaired using ascending aortic graft or subcommissal annuloplasty. In 1B, there will be dilatation of sinus of Valsalva as well as sinotubular junction, so which can be repaired using either reimplantation or remodeling. In patients who have 1C type of disease, there will be only dilatation of ventricular aortic junction, which can be repaired using subcommissal annuloplasty, and patient with 1D type of lesion, there will be perforation in cusp, which can be repaired using autologous or bovine pericardium. In type 2 patients, there will be prolapse of cusp, which can be repaired by plication, triangular resection, or free margin resuspension along with subcommissal annuloplasty. And patients who have cusp restriction, leaflet repair can be done by shaving the leaflet, decalcifying the leaflet, and patchplasty along with subcommissal annuloplasty. For aortic valve repair, we need to assess valve first. So the sequence will be assessment of the valve type, whether the leaflets are bicuspid or tricuspid, type of fusion is bicuspid valve, commissure orientation, and fusion completeness and incompleteness. Now we have to exclude the degenerative changes, like all leaflets have to be mobile, pliable, and free of calcification. Now we have to detect and assess for any kind of fenestrations, and because its presence is not a contraindication for aortic valve repair, and even large fenestration may not cause regurgitation because they are not included in coaptation zone, but they may pose a risk of future regurgitation. Now we have to measure geometric height of all cusps optimally by means of a special ruler. For feasibility of repair, the leaflet has to have a sufficient amount of tissue. If not, the leaflet is assessed as restrictive. A restrictive leaflet is classified in case of geometric height of less than 17 mm tricuspid aortic valve or geometric height of less than 20 mm bicuspid aortic valve. Restrictive morphology, even if present in one leaflet only, makes the repair option dubious and valve replacement has to be considered. Now we have to measure the effective height of all cusps by means of a dedicated aortic caliper. The effective height should be equal in all leaflets and within a range of 9 to 10 mm. The lower effective height indicates leaflet prolapse, which is the commonest leaflet pathology in aortic regurgitant valve. So this is the figure that in which A is the suggestive of effective height, B is the coaptation length, and C is geometric height. Now in cusp repair techniques, in patient with cusp prolapse, these are the techniques by which we can repair aortic valve. For aortic valve repair, it is vital to know about the Frater stitch or reference stitch. It is used for detection of leaflet edge redundancy. The Frater presumed that in a competent valve, the corresponding segments of all the coapting segment leaflets edges have to be equally long. So he temporarily sutured together all the three noduli aranti, which led to visualization of both the length redundancy and required shortening of the prolapsing leaflet. Three isolated monofilament sutures are passed through the center points of each leaflet's edge, and the corresponding edge segments are compared by pulling the opposite central points against the commissure. So, three, as shown in this figure, the three sutures are passed at the center of leaflet, and these are used as reference point for all the aortic valve repair techniques. So in case of central free margin plication, it is the commonest intervention on leaflet. It is performed in delicate steps on both sides of the nodules of aranti by means of monofilament suture 5O or 6O. The suture is passed from the inside of sinus of Valsalva through the edge of leaflet just adjacent to the nodule out and back again on the other side of the nodule. At tying of the suture, the central fibrous nodule is invaginated inside and a smooth coaptation surface is thus created. Additional plication sutures, if required, are taking the bites at both sides of previous plicating suture. In this way, the plicated and excluded area is extended and the free edge of leaflet shortened and its respective effective height is increased. So, increment in the effective height are controlled after each plication step by a caliper, and it guides the surgeon's decision about the required number of plication sutures. So this is the diagram showing central margin plication, which shows that monofilament 5 or 6 suture is passed on both the side of nodule of aranti, which is then tied and the redundant leaflet height is reduced. Now in free margin suspension, this is the original technique of leaflets edge resuspension is by its oversewing. Currently it is used seldomly, predominantly because of difficult foreseeing of the result, where the suture is passed through the whole length of the free margin of the leaflet, which are then taken out through the aorta and tied. Now in paracommissural plication, that is trussless repair, George A. Trussler introduced this in 1973, which shortens the edge of the prolapsing cusp. By subcommissure plication of Durand, the subcommissure part of the aortic valve leaflet is plicated using the plaited 5O or 6O suture, and as the subcommissure leaf triangle area is reduced, it leads to the most effective repair of aortic valve regurgitation. It is popular and simple and easily reproducible intra-aortic technique that reduces the aortic annulus circumference at the level of interleaflet triangles, which is the area of most frequent aortic annular dilatation. It is effective in significant reduction of the aortic annulus, increasing the effective height of the leaflets and coaptation surface area. The closer to the base, the greater is the annular reduction. Contrary, the plication suture applied close to the top of commissure has minimal impact on aortic annulus diameter, but it augments the opposition and coaptation of the leaflet. So the sutures should be passed at the closer to the base as possible. Now in patients with cusp prolapse, the prolapsing part of the cusp can be resected in a triangular fashion as shown in this figure. Now in patient with cusp perforation, the cusp perforation can be repaired using either a patient's autologous pericardium or bovine pericardium. In patients with restricted mobility of cusp, localized shaving and decalcification of cusp can be performed while leaving the cusp surface intact to improve increased mobility. Now, in patients who have reduced height of the cusp, pericardial patch augmentation of cusp can be done as shown in this figure. Now, in management in patients with aortic regurgitation with primary aortic root diseases. So, in patients with Marfan syndrome and additional risk factor, ascending aorta dilatation of more than 45 mm is the indication for the surgical replacement of ascending aorta, while in patient with bicuspid aortic valve, more than 50 mm diameter of ascending aorta is the indication for surgery, while in all other patients more than 55 mm diameter of ascending aorta is recommended for surgery. Now, for the dilatation of sinotubular junction, it means dilatation of ascending aorta. So, geometrically, the dilated sinotubular junction distracts the commissures of the aortic valve from the leaflets, and this leads to onset of central regurgitation. Reciprocally, surgical reduction of sinotubular junction brings the leaflets together, but it also induces their individual prolapse. This is the influence diagram showing influence of diameter of sinotubular junction on aortic valve leaflets, which shows as the sinotubular junction is dilates, the coaptation point gets away, and there will be central jut of aortic regurgitation. Now, it can be repaired with interposition graft by isolated supracoronary aortic replacement. The chosen size of vascular grafts means a new diameter of the sinotubular junction. The principle of surgical reduction of sinotubular junction is also present in complete aortic root replacement by a vascular graft, which is known as either remodeling or reimplantation. This is the diagram which shows, the first diagram shows normal aorta, the second diagram shows there is dilatation of ascending aorta, and the third diagram shows supracoronary aortic ascending aorta replacement using a tube graft. Now, in patients who have ascending root dilatation, it can be repaired using valve sparing root replacement techniques like David procedure, which is a reimplantation procedure. This means reimplantation of aortic valve in a tubular vascular graft after complete excision of dilated aortic root wall. It is one of the principal surgical aortic valve sparing techniques, and it is eponymously connected with the name of Canadian cardiac surgeon Tyrone E. David, who had pioneered it. In the David procedure, the dilated sinotubular junction and ascending aorta are excised and they are replaced using the tubular graft, and coronaries buttons are then reimplanted. In this technique, the aortic valve leaflets, the native aortic valve leaflets are preserved. In 1993, Sarsam and Yakub published a series of 10 patients with aortic regurgitation treated with what they term remodeling of the aortic annulus. The remodeling technique consisted of replacing all three sinuses with reimplantation of the coronary utilizing a tripartite crown-shaped Dacron tube graft. It required coronary implantation but did not provide stabilization of the aortic base or specific narrowing of the sinotubular junction. The advantage is that it is easier technically than the reimplantation method and provides a simple method for accurate resuspension of pillars. Subsequent modifications by Yakub include narrowing of the sinotubular junction and allowing the sinus reconstruction to bulge outward more so than in its first version. This is the diagram which shows the tailoring of the tubular graft as per the aortic valve leaflet and reimplanting it and in place of dilated sinotubular junction and ascending aorta. In this technique also native aortic valve is preserved. In David and Yakub procedure, the main difference is in David procedure the aortic sinuses are excised and aortic valve is implanted inside a cylindrical Dacron graft, while in Yakub procedure The aortic sinuses are excised and replaced with a tailored tubular graft and 3 neo-aortic sinuses. In patients in David procedure, the compliance of aortic valve is decreases, while in Yacob procedure, the compliance of aortic root is preserved. David procedure, it stabilizes the aortic annulus. Therefore, it is the procedure of choice in patient with Marfan syndrome. While in Yacob procedure, aortic annular dilatation or late aortic incompetence can be prevented. So, it is reserved for older patients with normal aortic annulus. Nowadays, Valsalva graft is available, which is a tubular graft along with the aortic valve, neo-aortic valve, which can be replaced for patients with aortic root pathologies. Now, for the medical management of chronic AR, there is no specific therapy to improve clinical outcomes in patients with chronic AR. It is recommended to treat hypertension, coronary artery disease, atrial arrhythmias, and any other cardiovascular comorbidities according to established guidelines. For symptomatic patients, chronic medical therapy may be necessary for some patients who refuse surgery or who are considered to be inoperable because of comorbid conditions. These patients should receive an aggressive heart failure regimen, which consists of angiotensin conversion enzyme inhibitors, diuretics, digoxin, and salt restriction. In patients who are surgical candidates but who have severely decompensated LV function, vasodilator therapy may be particularly helpful to stabilize them before the aortic valve replacement. In patients of acute AR, early death caused by LV failure is common in patients with acute AR, so prompt surgical intervention is indicated. While the patient is being prepared for surgery, treatment with an intravenous positive inotropic agent like dopamine or dobutamine and or vasodilatation like nitroprusside often is necessary. Beta blockers and intra-aortic balloon counter pulsations are contraindicated because either lowering the heart or augmenting peripheral resistance during diastole can lead to rapid hemodynamic compromise. In hemodynamically stable patient with acute AR secondary to infective endocarditis, operation may be deferred to allow 5 to 7 days of intensive antibiotic therapy. However, aortic valve replacement should be undertaken at the earliest site of hemodynamic instability or if there is any evidence of abscess formation. Thank you.